Hello, everyone, and good morning. My name is Woody Ebron, one of the Life Treaty Officers of NATRI, and I am your host for today. I hope everyone is safe and well, including your loved ones. So we are so delighted that you have joined with us today in this morning's webinar. So before we proceed with the webinar proper, allow me to first read our speaker's disclaimer. Effort is made to stick to facts and officially published numbers. However, due to the dynamic nature of the pandemic, numbers do change continuously, and there is a natural lag in reporting data. To properly explain the emergence of numbers, it may be necessary to express opinion and educated guesses. Any opinion expressed in the presentation is solely the speaker's opinion and may not reflect the sentiment of NATRI, the insurance industry, the actuarial profession, nor any other entity. The speaker is not a doctor and does not claim nor propose a solution to the pandemic. The presentation is meant to be a kind of introduction to COVID-19 for insurance practitioners. Just like in any issue of national interest, conflicting opinions and projections abound. It is very likely that this presentation will, um, will be in conflict with somebody else's presentation. Participants are encouraged to do more research on COVID-19. Thank you. Okay, so to continue, let us first go through a few house rules. This webinar will run from 10 to 11 a.m. The participants will be muted and the camera will automatically be turned off for the duration of the webinar. You may type in your questions in the Q&A box while the presentation is ongoing. This will be addressed at the end of the presentation. The presentation materials in PDF format, together with the recording of this webinar, will be available on NATRI's website for a week, starting on September 28, 2020. And for those who wish to request for a certificate of attendance, you may email Russell Agustin at russell.agustin@nat-re.com. So the certificate of attendance will only be given to those who attended the whole duration of the webinar. Okay, so this is it. Allow me to introduce to you our speaker for this morning. Our speaker for today is our FVP and Head of Life Reinsurance. He is an actuary by profession, having held chief actuary positions in Maxicare Healthcare Corporation, Asian Life and General Assurance, and Great Pacific Life, now Sun Life Direpa. So before joining NATRI in 2014, he was the head of corporate solutions of Philippine AXA Life. He is a fellow of the Actuarial Society of the Philippines and has served as a member of its Board of Governors several times. He earned his bachelor's degree in mathematics from the Ateneo de Manila University. So ladies and gentlemen, please welcome my boss, Mr. Vic Taniwakio. Vic, I think your audio, Vic, can you please unmute?
Good morning. Thank you, Woody. To everyone, welcome to the COVID-19 webinar, The Story in Numbers. As you know, last month we held our webinar, Underwriting Under the New Normal. And at the end of that webinar, we ask you, which topics would you wish us to cover? And one of the more popular suggestions is actually COVID-19. And so this is actually a response to that demand from you to have another COVID-19 webinar. And so this is our presentation, which I suppose should be interesting to both actuaries and underwriters. Next slide, please. So why don't we start with the numbers as of 2 days ago. So this is as of September 21. So you will see that half of the cases that's in Metro Manila, you see the blue dot in the middle of Luzon. That blue dot represents, I think, 55% of all cases, or about 154,000 cases. This is followed by the Luzon cases, or the yellow portion, with 40,000 cases. Then you have the green portion, Visayas portion, at 36,000 cases. And then lastly, well, actually not the last, we'll have Mindanao, 11,000 cases. We also have the repatriates, or the returning OFW, slightly bigger than Mindanao, with 11,600 cases. And then from the DOH data, we have the unlocated, no location indicated in the database, with about almost 5,000 cases. So that is the picture as of 2 days ago. But before we proceed, let me just go through a survey. I'd like to find out how you are experiencing COVID-19. So can we flash the question? Okay, so there are 3 questions here. I'm curious how you will respond to these three questions. This is more of a personal in nature and probably professional in your office work. So I'll give you 1 minute to reply to the survey. So once we have enough votes or enough responses, we will flash on screen the summary of responses. I'm curious how many of you are actually experiencing on a personal basis COVID-19. If you or somebody you know, a personal friend, a relative, a household mate, falling victim to COVID-19. Okay. So can we see the results now? So first question, do you know of a close friend or relative falling sick to COVID-19? About 60% said yes. How many people in your office got infected with COVID-19? The biggest answer is actually more than one. 52% said more than one. And has your company received a COVID-19 related claim? Well, surprisingly, a lot of you are not aware of any, but uh, there are at least 5% of cases of the respondents saying they receive COVID-19 claims on a weekly basis. So I think this survey shows that we are actually experiencing COVID-19 on a personal basis. So nararamdaman natin itong COVID-19. So thank you for responding to this polls. Next slide, please. So having said that, let me focus on fatality rates. As you know, we are in the insurance industry. In fact, we are in the life insurance industry, and our interest is typically about morbidity or mortality rate. So we start with this slide where I captured the screenshot of Wikipedia comparing the fatality rates of the top countries affected by COVID-19. So this is easier compared through a graphic form. So let me see the next slide, which is in graphical form. So here you will see that there are two countries with high fatality rates. So that's Mexico at 10%, and then about 12% for Italy, and another high point for Ecuador. Compare that with the low number of Qatar and Israel, which are both below 1%. So this wide variety or variation in fatality rates is due to a lot of factors, including political conditions, cultural condition. But I'd like to focus on the demographics as a basis for the wide variation in fatality rates. So we start with the Philippines, which is almost a perfect pyramid with the most number of people, the youngest being the most number of part of the population, and the least number of population is on the oldest part of the population. And the fatality, because of this kind of pyramid demographic, is just 1.7%. It's actually a low number. Compare that with the US demographics, which has a less number of young people. So I think the most number that they have is for the middle adult ages of 30 to 45. So their fatality rate is averaging at 3%. And then we again compare it with another country with high number of cases, that's India. It's similar to the Philippine demographics, except that the youngest population is not the most numerous, and their fatality rate is actually lower than the Philippines at 1.6%. We will see later how that happened. Okay. We further compare with two European countries, that's France at 7% fatality and Italy at 12.2% fatality. And the reason for this is if you look at the ages 60 to 69, they actually have more ages 60 to 65 than the younger ages of 0 to 10. Okay, and then we need to recall also that COVID-19 devastated a lot of nursing homes in Western countries, both in North America as well as in European countries. Then our neighbor, let's compare ourselves with our neighbor. The population demographic is almost similar to the Philippines, but their fatality rate is a little higher at 4%. And I'm guessing it's probably due to maybe less testing or less reporting of COVID-19 claims, death. So the country demographics has a significant impact on the fatality rate of COVID-19, but please be aware that other factors affect fatality rates too, including cultural, regulatory, as well as to a lot of countries, political factors. Okay, so what we can do is actually compare the fatality rates based on specific ages. So on the left-hand side, you'll see there different countries, Argentina with columns on ages 0 to 9, columns 10 to 19. And you will see, except for a couple of countries, the rates, the fatality rates by age, specific ages are actually very, very similar. So the exceptions are Mexico and the Philippines. But the Philippine number as of June 4 is high. As of now, today is September 23, it has come down already to comparable levels to other countries. And then on the right side, you will see the graphical comparison of 4 countries, China, South Korea, and Spain and Italy. And they have very, very similar fatality rates, except for the very old ages of 70 and up. So the question that is typically asked of a lot of actuaries that we encounter is, I'll just read it. I've been asked to provide death benefit for deaths due to COVID-19. How do I estimate the incidence of death? So this is what we'll do. We will refer to the Philippine mortality experience using the DOH database. You will find that in the DOH shared drive bit.ly/datadropph. And the specific file that you should look for is the DOH COVID data drop, and then you have the specific date for the database, case information.csv. The available data there are sex, age, and health status. You should count the number of people who died and the number of people who have recovered. And then finally, you apply a formula. Next slide. The formula is the death count divided by the death plus recoveries. So notice that we are not using the active cases in calculating the mortality. And having used that formula, we can come up with a graph that looks similar to the one on the right. So very, very low rates at the young ages, and it gradually increases up to 1,000 by age 100. In fact, we can do this on a specific ages. From age 0 to 20, the juvenile ages, it's actually very volatile. At the age 0, it's very high, I think at 30 per 1,000. And then by age 2 to 10, it's very, very variable or very volatile. And then by age 20 to 30, it stabilizes to a very, very low rate. And then sometime at age 30, male and female separates. And then both of them gradually increase to 1,000 for age 100. And you will see that we can actually come up with a mortality table for both male and female using simply the database of the DOH. Now, again, we are actuaries and we know that deaths are reported late, and we need to adjust this mortality table for the delays in reporting death. In fact, if you look at the next slide, this is the announcement of DOH on September 18. Notice that in September 18, about half of the deaths are actually reported late. So that's May, June, July being reported on September 18. Next slide, please. So we tabulate all of the reported deaths according to the date when it is reported. So the first column, the labeled 0, that is the number of deaths reported within the same week. And the next column, the one labeled 1, is the number of deaths reported 1 week later. And you will notice that the first two columns, they represent 60% of deaths, or the 60% of deaths are reported in the first 2 weeks of death. And then about 90% of deaths are reported in 8 weeks. To further illustrate how we can actually estimate the effect of this delayed reporting, we can look at the next slide. So what we do is we look at the August 31 database. So I screen captured the CNN data. So that's 3,558 deaths, and we can break it down into the month when it is reported. So about 1,554 is reported in August and 756 in July. And using the database of DOH, we can break it down into when they actually died. And you will see that in using this database, we can look at March, where it's actually reported over a 5-month period. So if March is reported over a 5-month period, then we can expect April also to be reported in a 5-month period, and then May also, and the same with July and August. So the question now is, how do we estimate the areas in red? And it's actually very easy. You have many ways of doing that. So at the bottom, you will see apply the insurance concept of IBNR, or incurred but not reported claim, and use the techniques in estimating IBNR. So in this presentation, I will use a very simple formula. We'll just average the prior column. So in the case of August, we will just pick up the number in March, and we will extend it over September, October, and November, just like that. And then for the next row, we will average July and August, okay? And then again, extend it for September and October, and we'll do the same for all the remaining months. So we'll have 112, and then we'll have 445. So this is just one technique in using IBNR, and we can estimate that the actual expected number of deaths for as of August is actually a much higher number, or about, if I remember right, this is about 33% higher. Next slide, please. So it's actually from 3,558, it will increase to a total of 4,400 deaths as of August. So in a graphical form, this is what actually happened. So when they are reported, this is what it looked like. And when we broke it down into the months when the deaths actually occurred, this is what it looked like. And we will gradually allocate this into the months when they are actually happened. So March, April, May is green, June is dark green, July, and August. So this is our best estimate for the respective months. And then we add as on top of all of them, the estimated unreported deaths to have a total of 4,400 deaths. Then again, as you know, today is September 23, and 2 days ago, we can actually tabulate the actual deaths as we have the most recent data. And we will compare our estimate with the emerging data. So let's see. So March is almost the same. Okay, you will see that it's almost the same. April is almost the same. We've underestimated both March and April, and then for July we have June we have underestimated, as well as for July we have underestimated. For August we have overestimated, but again this is an emerging data. So our simple estimation actually provides a reasonable estimate for the unreported deaths. So given that, we can actually adjust our mortality table using the table on screen. So the estimated unreported is in the middle column. So you have 6, 26, 61, and so on. And we divide that number, the middle column, by the reported death, and the required adjustment is on the right side. So if we use the July data for the mortality table, we need to increase the mortality rate by 9.5% to account for the unreported deaths. Or if we use the most recent August data, then we have to increase the mortality rate by almost 25%. So that's how we use the unreported deaths. So I think in the next slide, instead of the monthly numbers, I actually tabulated the weekly numbers, and this is I came up with. So this is the most recent week as of ending September 19. So if you use the September 19 cutoff, you have to increase the mortality rate by 33% because it's too understated. What I would suggest is to have an earlier cutoff where the adjustment will be 10% or less. So use the week 31 data instead of the week 37, which is still unstable in my opinion. Okay, so where are we now? So we said we will prepare the mortality table. So we've done that. So we'll put a check mark on that one. Step 2, we make adjustment on unreported deaths. So we've done that as well. So the next step is we need to make assumption on the community infection rate. As you know, the mortality table that we showed are for those who are infected. So for those who have not been infected by COVID-19, the mortality rate doesn't apply. So that means we need to make an assumption on the community infection rate. So this one is a long one, but before we proceed, I'd like to ask this question. Can we flash the question on screen? So I'm curious on how people interpret the flattening of the curve. So I'd like to ask the question, what does flattening the curve mean? So we have choices of reducing cases, level only cases. So that's a flat graph, not increasing. More recoveries than new cases, or delaying the infection of the population. So let's see how our audience actually understand the flattening of the curve. So I think a lot of experts have been touting that we have flattened, we have not flattened. Some critics would say we're unable to flatten the curve. Our Secretary of Health is saying we have flattened the curve since day one. And then we have critics saying we're increasing the curve or fattening the curve. So let's see how our audience view the meaning of flattening the curve. We have 80% of the votes now. Let's see how the audience is voting. Okay, a lot of people said reducing cases. The most number of answer is actually level only cases, not increasing. So almost tayo sila. No more recoveries than new cases. And then delaying the infection of the population. So all of you answered varying questions. So just to let you know, my opinion, so this is my opinion, all of these answers are actually correct. If you look at all of the pronouncement, all of these approaches actually apply to flattening the curve. But my next slide will be a more meaningful one. Can we see the next slide? So this one is from Wikipedia. So I copied both the graph and the definition. I'll read the definition in Wikipedia. So the assumption in Wikipedia is the whole population actually will be infected with the infectious disease, which in this case is COVID-19. So it says, progressively stronger mitigation efforts to reduce the number of active cases at any given time. So that means delaying the infection rate So flattening the curve allows the healthcare services to better manage the same volume of patients. So what we're doing is we are delaying the infection of the population so that just enough infected people will be accommodated by the healthcare facilities. So there are two action points in flattening the curve. One is we are delaying the infection of the population, thereby lengthening the infection period. And then we are also increasing the healthcare capacity. So if you're aware of the isolation facilities of the local government units, that's actually what they're doing. They're increasing the healthcare facility so that we can accommodate the curve or the active cases. So at the bottom, I've written there, flattening the curve involves delaying the infection, and what we are monitoring are active cases. And then aside from active cases, we are also reducing new cases, and we are increasing the healthcare facilities. So does that match the answer that you replied in the survey? Okay, let's look at the next slide where the DOH is monitoring the facility. So it says here, ICU beds, according to DOH, only 50% are occupied. Isolation, 44% are occupied. And so if you look at this slide, you will, if you're DOH, you'll probably conclude that we have flattened the curve. But I'd like to call attention that this is a nationwide set of numbers. So 50% of the nationwide ICU beds are occupied and 50% unoccupied. But it doesn't mean that on a local basis, there's no maximization of the facility. So let's look at the next slide. So you'll see here the availability of healthcare facilities. So in the case of Makati Medical, as early as April, it's no longer available, and then it's got freed up sometime in June. And then in the months of July and August, it's also again full capacity. And it's the same for St. Luke's Global and Quezon City. In fact, St. Luke's Global and Quezon City are not available for about 4 months. So full capacity siya for about 4 months. And then the same is true with Chinese General Hospital. Then what about as of now? So as of now, almost all have available room, but nearing full capacity. And there's another advisory that says patient to be admitted only if life of patient is at risk. So whether that is flattening the curve or not, I will leave it up to the audience to make a decision for themselves. So next slide, please. So again, we said flattening the curve means monitoring the active cases. So let's look at the active cases in the Philippines. So this is how, previous slide please. So this is the active cases for the Philippines. You will notice that it's somewhat erratic and jumpy, and that is because of the periodic cleanup of the DOH. But notice that the high points is actually going down, and the low points are actually going down. So my opinion is that it's actually going down, and on a nationwide basis, we might be actually flattening the curve. Again, this is on a nationwide basis. Let's look at a local basis. Next slide, please. So for Metro Manila, it's actually going down much faster than the nationwide basis. And then in Cebu, you will see that it's actually has flattened almost to near zero level. And then in Calabarzon, it's somewhat similar to Metro Manila, except that it's actually not reducing. And in my opinion, it's in the last couple of weeks, it's actually increasing for Calabarzon. And then just to give an exception to the rule, look at Negros Occidental. So that's Bacolod. It's actually increasing. So definitely the curve is not flattening in Negros Occidental. And then some other local places. So this is Luzon, excluding Calabarzon. It's actually increasing. And then Visayas, excluding Cebu and Negros, it's somewhat mixed, but in the last 10 days, it's actually increasing. And then Mindanao, the whole of Mindanao is actually increasing. And then repatriates or those with no labels, it's actually reducing. But look at the last, I think 10 days or last 2 weeks, it somewhat indicates an increasing trend. Okay. And then this one is not actually active cases, but these are new cases for the selected cities or towns. So in Mariveles, there's an increasing number of cases. Santo Tomas, Batangas, again, increasing cases. In Butuan, Agusan, it's erratic. So kuminsan nagsi-zero, kuminsan nag-high. It's an erratic number, but it's increasing trend. And then again in Mindanao, Cagayan de Oro, it's also increasing. So again, we go back to the question of infection rate. So what infection rate should we assume? So let's look at the survey. So in April, we had a very, very low infection rate. So infection rate is total number of infected divided by population. So for the whole of Philippines, it's about 0.25% of population as of September 21. But for Metro Manila, it's actually 1.1% already as of September 21. And then if we assume a doubling every 45 days, by December 31, we should be hitting 4% infection rate. And then if we compare ourselves with Brazil, Brazil it's I think at 2.1%. And then a couple of other countries, India and Mexico, which are probably culturally similar to us. They're actually below Metro Manila level, but higher than the Philippine level of look at Mexico at 0.5%. And then we compare with the other countries. This one is as of September 15, Indonesia at 0.08%, India, Israel at 1.76%. And then some other comparison on the next slide. So this one is a more numerous number of countries. We have Brazil, Bolivia on the left side, and then on the right side you have Kuwait, Argentina. Mostly are below 2.5%. The Philippines is at the bottom. That's at 0.25%. And the highest is Qatar at almost 4.5%. I'll use this as a basis for making assumption. I'd say it's very realistic for the Philippines to hit any of these numbers. In fact, Metro Manila can hit any of these numbers. As even the Qatar number of 4.5% is realistically within reach of Metro Manila. So I'd say we can use as an assumption 4.5% as a possible infection rate. Maybe we should also talk about the factors affecting the spread of COVID-19. So I put on screen the population heat map. So population heat map means the red portion indicates where the population is. So you will notice where the population is, there's also the COVID-19. So Metro Manila, Bulacan, Laguna. The numerous population also indicates numerous COVID-19 cases. So conclusion, big population causes wider and faster spread of infection. So I think that's fairly obvious. So why don't we map the most infected cities? So on the left-hand side, we'll see there the most infected: Quezon City, Manila, Cebu, Caloocan. Down at the bottom, Bacoor and Mandaue. We have the infection rate on the third column. And then we compare that with the most populous cities. So in theory, we should have the same names of cities in both lists. But you'll realize that there are actually differences. The most populous cities, next slide please. You'll see that Davao, the third most populous city, actually has only an infection rate of 0.1%. Zamboanga at only 0.17%. Cagayan de Oro at 0.09%. General Santos City, which is still in the top 20 at only 0.04%. And the key to these differences is the last column, which is the population per square meter. So that's the congestion, city congestion. So the city congestion actually affects the spread of COVID-19. So on the next slide, I have plotted the infection rate against the congestion rate. So on the right side, you'll see the higher congestion, and then the higher side, you'll see the higher infection rate. So on the lower left-hand side, prior slide, please. You'll see, can you go back? You'll see Zamboanga, Davao, General Santos on the lower left-hand side. And then on the upper right-hand side, you'll see Pasay, Makati, Malabon, Mandaluyong, and then Taguig. And I'd like to generalize this somewhat into a formula. The next slide, you'll see that there's somewhat of a correlation. So the higher the congestion, or the higher the density, population density, the higher the infection rate. Okay, next slide, please. So there are two exceptions, Cebu City and Manila, and Cebu is actually still a highly congested city despite the graph on screen. But I'll not go into that anymore because we might run out of time. So I'll go straight to the other factors affecting spread of COVID-19, which is mobility, or the movement of people. Maybe you have watched the Netflix show, what do you call that? It's about technology and social media. I think it's very critical of the social media, and this slide actually shows you the good side of the social media. It says here that technology company Facebook, Apple, and Google are actually working towards helping pandemic experts curb the COVID-19 spread. And what they're doing is they're sharing with us, even as lay people, the data on movement. So if you're using Waze, if you're using Apple or Facebook, just to let you know, all of these companies are tracking your movement. So let me show you the details of that on the next slide. So for instance, this one, at the bottom, you will see the movement as published by Facebook. So sometime in the middle of March, there's a vast reduction in movement in the Philippines. So the blue line represents the reduction in people movement in the Philippines. And if we superimpose these two graphs, so the top graph and the bottom graph, you will see that they actually almost coincide. So may konting delay lang, no? When we reduce the movement in the Philippines, there's actually a reduced number of deaths nationwide about 2 to 3 weeks later. Next slide, please. Yeah, let me show you. So when we reduce movement, there's a a reduction in number of deaths 2 weeks later. And then when we increase the movement, 2 weeks later, there's an increase in number of deaths nationwide. And then next slide. This is more recent one. Sometime on August 1, our frontliners called for a timeout. And then 2 days later, there's somewhat of a panic. So there's an increase in activity. So they peaked in movement. And then we had a MECQ. So we have a reduction in movement on August 5 to 18. And 2 weeks later, there's a reduced number of COVID-19 cases as evidenced by the lines in black. So reduced number and reduced movement, there's a reduced number of cases 2 weeks later. Okay, next slide. And then what other effect of the mobility? So because we are not allowing the senior people and the juveniles to move out of the house, so from the March demographic to the August demographic, it's actually a very different picture. So very, very few juveniles are affected by COVID-19, and very few of the senior people are affected by COVID-19. So it's mostly the working ages that are affected. So compare that, for instance, with the Philippine population. So konti lang yung juvenile and konti lang yung adult age, senior ages. Next slide, please. So I have some other notes on the infection rates. So it would be best to refer to projection of pandemic experts for guidance. So I have here two websites. So that's a UP website and the USA website, COVID-19-projections.com. So that's for the Philippines. Typically, published projections are usually of short-term duration only, like 30 days or 60 days. And the latest forecast of the UP Octa research is 500,000 cases before year end. And what you need to project is actually not the total number of people infected, but those who will be infected during the indicated period. So if you're looking at 2-month period, then who will be infected in the 2-month period only. Okay, so our conclusion, so big cities drive epidemics, congestion magnifies epidemics, movements has a huge impact on transmission of COVID-19, but it is not the sole driver of infection. And then finally, working ages are the most affected because they're the most frequently moving type of people in the Philippines. Okay. So what we have done so far, we've done a mortality table. So put a check on that one. We've done adjustment on the unreported deaths. We'll put a check on that one. And then we have just made assumption on the community infection rate. So we put a check on that one. So in computing for the incidence of death, we put the mortality rate adjusted for unreported and then apply the infection rate. So given all of those three items, we can now estimate the incidence of COVID-19 deaths. Okay. So we now move to another set of questions. So another set of questions says, I've been asked to provide a second layer hospitalization benefit for COVID-19 cases. How do I estimate the cost? And then we want to provide free medical coverage, even though it's an exclusion. How much will it cost? So presumably these questions are coming from a medical insurer with hospitalization experience. So what we do is we tabulate cases into mild, severe, and critical. And then again, we will refer to DOH later on. Then we have available the average cost for mild, severe, and critical, or in some cases, asymptomatic. And then again, we will refer to the data as indicated in the bullet and then apply the formula in number 4. Medical cost is the infection rate. Again, we go back to the infection rate. And then some of the incidence of each category. So I'll show you on the next slide what the DOH database shows on the categories. Next slide, please. So according to, I think this is September 19, there are asymptomatic and then you have mild, severe, and critical. So according to this table, less than 1% are severe and critical, and then the vast majority are mild, and then about 5% are asymptomatic. But again, as you look at the older ages of 50 and up, the severe and critical actually increases. So depending on the age, the medical cost might increase because of the more frequent cases of severe and critical cases. But I put a note there at the bottom. You need to validate this first before using, because as I mentioned earlier, the mortality rate for the Philippines is about 2%. And then if you look at this one, severe and critical at 1.2% only. So why is that less than the fatality rate? So makes you wonder. So we need to check this and verify the numbers provided by the DOH. Okay. So we are now about to finish our part on the estimation of claims, and maybe we should also cover the cases where the underwriters of interested. So how do we now underwrite COVID-19 cases? I think all of the underwriters know that there are comorbidities affecting this infectious disease. And I think a lot of you will say, oh, obvious naman yan. So pag may cancer, chronic kidney disease, COPD, obesity, then those are at increased risk of severe illness from COVID-19. So I think you'll agree with me on this slide. On the next slide, the CDC says, this is coming from the CDC website or the Center for Disease Control. It says here, might be at an increased risk, so not conclusive, no? So asthma, cerebrovascular disease, HIV, liver disease, pregnancy, smoking, and type 1 diabetes mellitus. And on the next slide is actually a citation of evidence by the CDC. They're saying there's very limited evidence to support the hypothesis on bone marrow transplantation, HIV, immunodeficiencies, liver disease. And at the bottom, you'll see there type 1 diabetes mellitus. So there's not enough evidence to support watching out for these diseases. And then in the second box, it says here, there's actually mixed evidence. So there's enough evidence, but the results are mixed for asthma, cerebrovascular disease, hypertension, pregnancy, smoking, and this other line, use of immunosuppressive medication. And lastly, they're saying there's a very strong evidence and consistent evidence that these diseases actually exacerbates COVID-19. So that's cancer, chronic kidney disease, which is very frequent in the Philippines, COPD, obesity, and at the bottom you'll see there, opposite is type 2 diabetes. So I think the data is still emerging, and there's no, shall we say, material evidence on the long-term impact of COVID-19 on the longevity or the long-term effect of COVID-19 patients. So the survivors or the recovered patients, we don't have data because this is a less than a year experience so far. I think this is the last of my slide. So I guess that ends the formal part of the lecture, and I think I'd like to turn over the floor to Woody and to thank the audience for listening in this webinar.
Thank you, Vic. So, well, can I just remind everybody, you can, if you have any questions, you may type in your questions in the Q&A box. Okay, let me just check, no? Okay, so we have one question here, Vic.
Mm-hmm.
This is this is from Bless of Natri.
Mm-hmm.
From the sales point of view, in your opinion, do you think this is the best time to develop a COVID-19 insurance product? If so, what would be your advice?
That's actually a very interesting question, because if you look at all of the experts making projections, you will not see any long-term projection. You will not see a 2021 projection. You will not see a 2022 projection. And my take on this is that all of the experts are anticipating that there will be a vaccine available sometime either in the early 2021 or probably in the middle 2021. So if you're going to introduce any COVID-19 product, you might as well introduce it now, because there's a very limited time of its relevance. By mid-2021, it's probably irrelevant by that time. No more meaning to that product at that time. Thank you, Woody.
Okay, let me see if there are any other questions. Mm-hmm.
One of the more interesting questions that I've always encountered is, what is my projection for the year-end numbers? That's a very difficult question. As mentioned in my presentation, you have many factors affecting the infection rate. So if you clamp down on the movement of people, then the numbers will be reduced. If we go to a modified GCQ, I am sure COVID-19 will spread faster. So I'd like to not probably mention my projection, but I'd like to agree with the projection of Octa Research of 500,000 Filipinos being affected by year-end. So other than that, I think it's a very fluid situation in the Philippines.
Okay. So wala na, mukhang wala na tayong questions here. All right. So so before we conclude this webinar, okay, may I request everybody, our attendees, to answer the feedback form on the topic and our company, Natri. You may click on the link that is posted in the chat box.
Woody, there's
Yes.
another question here. Anonymous attendee says, did you try other methods to calculate IBNR? Actually, I didn't. There are other methods I'm sure that you are the actuaries on the audience in the audience are familiar with. You can apply the formula that is you find more suitable, and there's actually no argument on that one. So the formula that I illustrated is for actually laymen, because I'm anticipating not all people in the audience are actuaries. So some of the people in the audience are underwriters who are not familiar with IBNR. So I just use a very simple formula where people can agree with. But I'm sure experts in the audience can use a more appropriate IBNR formula. So to answer you, no, I didn't use another formula for IBNR.
Okay.
Okay. Meron pa isang question, Moody.
Oo nga, may pumapasok na. So what can you say about HMOs and insurance companies covering COVID-19 cases on ex gratia basis? Is it wise to do this until year end or until next year given your projection?
I think this is more of a marketing question rather than an actuarial question. I think from the marketing point of view, you will be ostracized if you stop covering COVID-19 because everybody else is covering it. And from what I understand, there's actually a savings on other medical cases, like the outpatient cases have dropped significantly because everybody's afraid to go to hospital. So I think those savings can be passed on to the members of HMO, and by providing the HMO, providing the members with COVID-19 coverage despite it being an exclusion. But I think the safer way to do it is provide it on a clearly ex gratia basis, that you can withhold sometime or stop paying sometime in the future. So continue until you can afford. If you cannot afford, then I guess you have to stop paying it.
Okay, so by the way, this question was from Jeronimo Francisco. And the previous question was an anonymous attendee. Oh, we have another anonymous, a question from an anonymous attendee. For medical insurance claims experienced during COVID, including non-COVID claims, did it increase or decrease? Because people are afraid to go out for checkup now.
Unfortunately, I cannot answer that definitively, but I can tell you what people have been telling me. I think what they're saying is overall the claims experience has gone down overall. That is by, I think, as of August, it has gone down. But as of September, it has already started increasing. And for the most people that I talked to, they said they expect the claims to go back to normal level soon. But as of now, it hasn't gone back to the normal level. It's still below normal. But they expect it will go back to normal soon.
Okay, thank you, Vic. Oh, will there be any other questions? Ayan, sulat yun na lang sa Q&A. But while we can still, there's another one. Ayan, ang daming questions. From another anonymous attendee, is there any emerging studies or trends showing long-term effect of COVID-19 which may impact future health conditions or underwriting?
In terms of studies, because you're asking for studies, there's no study yet, but there are anecdotal stories talking about what they call long haul or long haulers. These are the people with have long-term effects of COVID-19, and I think the effect is mostly on neurological effect. They're saying cloudy thinking or foggy thinking. So parang clouded yung judgment nila, or affected yung consciousness nila affected. So, but other than that, other than anecdotal stories about those long-term holders, there's actually no study yet. I think they're starting with the study, but it's still 6 months pandemic. So I think there's really no conclusion on that one yet.
Okay, thank you, Vic.
Let's give them 30 more seconds if there are additional questions.
probably while you're still contemplating on some questions to ask, we can invite you also to go to this link. You can scan the QR code or go to the link in our chat box. We would love to hear from you. Any feedback, about this topic or about NATRI. Please share with us your thoughts, and we'll give you. Okay, Vic, while they're doing the we're answering the form or the survey, there's another question here coming in, another anonymous attendee. When do you think will a vaccine reach the Philippines, and how will this affect the insurance industry?
That one is a difficult question, but I think if it reaches any country, it will reach the Philippines. I mean, I don't think there will be many months of delay if gets launched in the US. Within weeks, it will reach the Philippines. So I don't think there's a big deal of when it will reach the Philippines. It's really more of a question of when will the vaccine be developed. And from my reading, I think most of the estimates are in 2021. The earliest estimate, I think, is April 2021, while most of the consensus is mid-2021. How will this affect the insurance industry? I think it will be, again, back to normal. Not much impact on the insurance industry.
Okay.
There's another question, I think.
Yeah, there is from Emeline Ramos. Will there be a need to impose changes on the current underwriting guidelines given the higher mortality rate for people with diabetes or hypertension due to the impact of COVID-19?
Okay, this one is a question for underwriters. As of today, what I'd like to use is the word guarded. We should be guarded against this one, but I don't like to impose higher rates as of now for those people. As I've mentioned in the citation in the last slide, there's actually strong evidence on type 2 diabetes, but there's no evidence for type 1 diabetes, and there's some mixed evidence for hypertension. So if you ask me, it's not very conclusive at this time. So I'd like to say we must be guarded against it, but I don't think it warrants an increase in rates at this time. So maybe what we can do is probably limit the amount of coverage, but not yet increase the premium rates.
Okay, so probably one last question, Vic.
Mm-hmm.
There's an anonymous attendee here who wanted to ask, do you think there may be frauds involved at hospitalization stage related with COVID? If yes, how do we factor them in pricing?
Okay, this is somewhat difficult to answer. So what kind of fraud? So the kind of fraud that people have been telling me are actually unnecessary hospitalization. So if you're calling that a fraud, then probably that's a fraud. So what they're saying, they're actually not required to go to hospital, but because they want to evade the isolation facility, so they'd rather be hospitalized than go to an isolation facility, then probably there's an, shall we say, abuse of hospitalization rather than an outright fraud. Other than that, I don't see any other fraud in COVID-19.
Okay.
So I think it's a very limited occurrence, so I'm not too worried about fraud in COVID-19. In fact, a lot of people would probably avoid going to hospital. So why would they want to do a fraud if that will mean going to hospital when they don't need? I don't think there's a huge number of fraudulent activities in COVID-19. Thank you, Woody. Thank you for all of those questions.
Yeah, well, I guess we don't have any more time for a few more questions. So thank you, everybody. We have come to the conclusion of our webinar. I do hope you were able to do the survey as well while we're doing the Q&A portion. Thank you for participating, and we hope this has been an enriching experience for everybody. We are looking forward to seeing you in NATRI's future events. Thank you, everyone. Stay safe and stay well, and good day. Bye-bye.
Thank you.